Welcome back to Smitty's Learning Room. Today we're going to have a look at the focus question, what are the priority issues for improving Australia's health? More specifically, we're going to have a look at the groups experiencing inequities. So if we have a look at Australia, we know that we're a very multicultural country and we have various population groups within our societies. Now, let's have a look at some of the population groups which are experiencing health inequities. And having a look at this graph here, we can clearly identify that Indigenous Australians from a low socioeconomic status, and Australians living outside major cities, so in rural or remote areas, have a higher death rate compared to the rest of Australia. So we have a look at the 5 groups which have been identified, and we look at ASTI, so Aboriginal and Torres Strait Islander people, socioeconomically disadvantaged people, so those people living in a low socioeconomic status, people with disabilities, people in rural and remote areas, so those are areas that are outside of major cities, and overseas born people, so people who were not born in Australia. Now, these groups have been identified as groups that require extra resources and funding that help close the gap in health outcomes between these groups and the rest of the Australian population. Now, the syllabus requires us to research and analyse Aboriginal and Torres Strait Islander people and one other group experiencing health inequities by investigating the nature and extent of the health inequities, the sociocultural, socioeconomic and environmental determinants, and the roles of individuals, communities and governments in addressing the health inequities. In the first video, we had a look at ATSI people, and in this one, we're going to have a look at people in rural and remote areas. We'll start by having a look at the nature and extent of people living in rural and remote areas. More than 30% of Australia's population lives in a rural or remote area, and the health of people living in rural and isolated areas is poorer than that of people living in built-up or city areas. And you can tell by having a look at this graph here that the further away you get from the city, the higher the mortality rates per 1,000 in the population. So you can see here in the major cities here, and comparing that with very remote areas, you'll see that the deaths per 1,000 increase. Identify that although mortality rates across all of these regions have been decreasing in the past 10 years, the mortality rate for other regions has remained 10% higher than the mortality rate in city areas. This does not necessarily mean that remoteness or being far away from a city area means that you have poor health. There are individuals and groups that are obviously in remote and rural communities that have good health. And the poorer health status of Indigenous Australians is to some extent responsible for these higher rates. So obviously in rural and remote areas, you have a higher proportion of Indigenous people living in these areas. Having a look at the second graph over here, we see that people living in remote areas are obviously high smokers, have low levels of physical activity, they drink alcohol to a risky level, and because they're physically inactive, they're most likely to be overweight or obese, which obviously leads to high blood cholesterol. So if we have a look at the risk factor percentages, they're obviously a lot higher in the regional and remote areas to what they are in major city areas. So to further explore rural and remote populations, we need to have a look at the determinants. So again, we look at the sociocultural, socioeconomic and the environmental determinants, which can affect the health of people living in rural and remote areas. So just revising that the sociocultural determinants are family, religion, peers and media. So having a look at the sociocultural factors that influence those people living in rural and remote areas, it's important to note that obviously a higher proportion of people living in rural and remote areas are ATSI people. So there's an increased population. So obviously the epidemiological data from ATSI populations are going to contribute to the same data for people living in rural and remote areas. So these poor indicators of health, these sociocultural determinants, not only impact the ageing society of this area, but also impact the children that are being brought up in these rural and remote areas. Children in these areas are more likely to participate in behaviours that their parents or adults within the community that are engaging in. So, for example, children raised in these families have higher incidence of smoking rates, whether they're smoking themselves or they actually have higher rates of secondhand smoke and are more likely to become smokers later on in life. The same concept for children of overweight and obese parents are more likely to be overweight or obese. This also applies to lower rates of inactivity and higher risky drinking and cholesterol levels. So obviously this is similar for children who are living in any areas who have parents that are engaging in these risk-taking behaviours, but obviously these risk-taking behaviours are higher in rural and remote areas, hence why there's more of a concern for children. So next we have a look at the socioeconomic determinants, and remembering that these refer to education, employment and income. Now obviously looking at people in rural and remote areas, there's quite a few socioeconomic determinants for these people. And when we're having a look at it, we look at that they're largely disadvantaged in regarding their education and employment opportunities, obviously their income and access to health education. So if we have a look at the employment for people in rural and remote areas, there's a lot of people that work in high labour work industries. So therefore there's an increase of hazards that are associated with working, say, on farms or in the mines, which are obviously really hazardous occupations, which are prone to higher rates of tobacco and alcohol use. Because of lower income levels for people living in rural and remote areas, they're less likely to access education, so therefore their education levels are decreased, which pretty much means that their health literacy levels are quite low as well. I guess when we have a look at a positive aspect of people living in rural and remote areas, their social awareness and level of connectedness is quite high compared to other areas. So in summary, we're basically going a low income equals low access to education, low levels of health literacy, so more or less contributing to lower levels of health overall for people living in rural and remote areas. Now we'll have a look at the environmental determinants, and obviously when we look at the environmental determinants, we're looking at geographical location, access to health services, and technology. If we have a look at the number of doctors or general practitioners in rural and remote areas, these are actually rising. However, access to medical services such as x-rays and screenings are actually lower for those people living in rural and remote areas. So that basically means that there are lower levels of medical specialists and medical technology for people to access medical services. So obviously some cancer screening programs such as bowel cancer or people with kidney diseases have to travel long distances on a regular basis, obviously because they're in such remote areas, to access dialysis support. So when we have a look at all these determinants combined, the socioeconomical, the sociocultural and the environmental determinants, you can actually see that there's quite a lot of things that interact here and that can affect the health of people living in rural and remote areas. Finally, we're going to have a look at the role that individuals, communities and governments play in addressing the health inequities that exist for people living in rural and remote areas. Look at how individuals can improve their health. I guess start by doing this by looking at the concept of empowerment to try and increase their levels of education, employment and positive health choices. Obviously, if a young person stays within schooling and seeks further education, say either via rural universities, they're obviously going to have a higher chance of being employed beyond their schooling. Individuals can also empower themselves and other people within their community and their peers to make positive health choices as well, such as limiting their alcohol intake or not smoking at all. Because the level of social interaction amongst people in rural and remote communities is so high, the communities have a really important role in providing health services to reduce health inequities to people living in rural and remote areas. And you'll see that in these communities, there's a lot of multi-purpose health centres, community health centres, and community health groups, which all work towards providing basic health needs and reach out groups for people who require assistance. So, for example, it might be cancer survivors group, or it could be a discussion group for people suffering from mental health issues. The final group we have a look at is the government. Remote communities to try and the Royal Flying Doctor Service. And the Royal Flying Doctor Service provides services such as healthcare clinics, medical evacuations, medical chests, and remote consultations for people who are living in rural and remote areas. The government has also invested in the remote GP program, so basically having a look at increasing the amount of doctors in rural and remote areas to try and decrease the health inequities as well. So in wrapping up, having a look at the rural and remote population group, it's important to understand that their mortality rates are higher than those people living in the city or built up urban areas. And this is mainly due to the fact that the HSC, so the Aboriginal and Torres Strait Islander people population, are higher in those rural and remote areas as well. So not only have you got the fact that you've got one group of people that are living in rural and remote areas, but you also have another priority population group in the HSC that are also living in those areas that are contributing to the nature and prevalence of health in that area. So that's why their levels of health are so much lower than what the levels of health for people living in city and built up areas are.